7 audio lectures. So the first two we looked at the axial skeleton. Now we're going to look at the first part of the appendicular skeleton, which is going to be the upper extremity. And then we'll finish chapter 7 off by coming back and looking at the lower extremity. Okay, but one of the first things you always want to do, and again, this is for you have some people that have taken anatomy before, maybe in high school, or they've taken another class at the college, but you just want to kind of learn the basics first. Okay, so we looked at the skull. We looked at the vertebrae. Those are kind of different for everybody. Sometimes when you move on to the appendicular skeleton, people are a little bit more familiar with the arms and the legs. So the first thing I really want you to do is just make sure you know what the main bones are. So make sure you know that this is the scapula, this is the humerus, this is the femur, this is the tibia. Sort of just go through and just learn the normal, just basic names to start off with. And then once you have a good handle on just what each bone of the body is, then we're going to look at the specific structures on each bone that you're going to be responsible for. So in this one, you have your list from your objectives, for your lab objectives. But you really want to be very comfortable with, like, okay, if he gives me a picture of the proximal humerus, what structures am I going to be looking for? If he gives me a picture of the distal humerus, what structures is he going to look for? And you want to be able to sort of list those so that when they pop up on your test, you sort of say, okay, these are the main features of that part of the bone. Okay, so make sure you can just label each bone individually, the basic name, and then we'll start looking at all the features that are in each bone in the proximal and the distal part. So appendicular skeleton, we're talking about the bones of the limbs and the girdles. Okay, so we said axial skeleton was just down that midline, rib cage, vertebrae, skull. And then when we're looking at the appendicular skeleton, it's basically just everything else that we didn't cover in the appendicular part. Okay, so we have two girdles. This is the part that's maybe just a little bit trickier, but we have a pectoral girdle, okay, that's going to attach my upper limb to the body. And then we're going to have a pelvic girdle, and that's going to attach the lower limb to the body, okay? And these are really, the spinal cord kind of runs through the vertebrae, and the brain is protected by the skull. So those ones, they do provide some movement, but their main job is protection. But when we're talking about the appendicular skeleton, we're mostly talking about movement, okay? So your limbs are going to enable movement. They're going to also enable us not just to walk around, but they're going to allow movement that's going to allow us to manipulate our environment. So don't forget that one, because that one is one that people forget on the multiple choice questions. We just think about walking and running and jumping. But, our upper extremities more, we're manipulating our environment, using tools, using computers, building things, doing a lot of things like that too. Each limb is going to be composed of 3 major segments. And again, these segments, or each one of these bones, is going to be connected by a movable joint. And then we're going to come back and talk about joints in chapter 8. And we'll look at all the main ones of the body. So what are we talking about when we talk about the pectoral girdle? We're really talking about the shoulder, or the shoulder girdle, and it's going to consist of the scapula, we're going to look at it in a second, posteriorly, and the clavicle, or the collarbone, and that's going to be in the anterior segment. This is a question that comes up all the time, of like which bones are included in the pectoral girdle, and the one that everybody throws in here is the humerus, okay, or that upper part of your arm. So you just want to remember, for multiple choice purposes, that the pectoral girdle is just the scapula and the clavicle. We haven't added in the actual arm yet, okay? So just a thing that a lot of people kind of mix up, that people get wrong on tests all the time, just for you guys to be aware of. So we're talking about the clavicle, okay, and this is going to attach to the sternum and the scapula anteriorly. This is, again, the collarbone. The scapula is going to be attached posteriorly only by muscles. This is a really important thing to remember too. We're going to come back to this when we look at the muscle chapter. But your scapula, it has limited attachments actually to your spine. It's really just attached to the body mostly through these muscular attachments, okay? And we're also going to have a bunch of muscles that are going to attach to the scapula itself. So your shoulder joint has the greatest mobility of any joint due to these limited attachments. Again, we said we don't have a lot of big ligaments kind of holding it in place. We also have this shoulder socket that's going to be pretty shallow. And then we want to just come back to and touch on this whole, when we talk about joints, and we're going to talk about stability versus mobility. You can't have both, okay? So we either have joints in the body that are very stable, and those are going to lack motion, or they're going to lack mobility, or we have joints in the body that have a lot of mobility, and those are the ones that are going to lack stability, and this is going to make them a little more vulnerable to injury. So if we have a ton of mobility, we're going to have less stability, we're going to be more vulnerable to injury. Your shoulder joint has the greatest mobility. You can move it in every direction that you can kind of think of. But because of this, it's going to be a little bit more vulnerable to different kinds of injuries. So just something to kind of keep in mind as we move through all these next chapters. So here is a picture of the bones we just talked about. So here is my clavicle, and I can see I'm in the front part of the body because I can see the sternum. And then I can see my scapula here on the back side of the ribs. and I can see where my clavicle comes up, and it's going to meet up with my scapula at this AC joint or this acromioclavicular joint, which is just that big bony spot on the top part of your shoulder. Okay, so again, you want to palpate these things. Use your fingertips, find your clavicle, find your sternum, follow that clavicle to the side. You're going to run into this bony spot here, and that's going to be that acromioclavicular joint. Okay. Okay, so now we want to talk about just the clavicle a little bit. Again, this one's more commonly known as the collarbone. It's going to anchor muscles. It's going to act as a brace, so it's going to hold the scapula and the arms out laterally, kind of keeps it to the side of the body. If fractured, another important part is that this whole shoulder complex is going to kind of collapse entirely. Okay, so it's going to be hard for us to keep that arm out laterally if that collarbone kind of breaks. It's going to also transmit forces from the upper limbs to the axial skeleton when we're pushing. It's going to have two attachments, so it's going to have a sternal end that attaches to the sternum, and then it's going to have an acromial end where it's going to come and articulate with that scapula. Okay, it's going to fracture easily, and most of the time when you break your collarbone, it's because you fall and you put your arm out to break your fall, and we end up breaking that collarbone. So there's probably a bunch of us in our class that, if you've cycled or you've been on rollerblades or different things like that, where you've kind of fallen and you might have broke your collarbone. This is a picture from the Blackhawks a couple years ago. My son and I were kind of watching this game, and this guy actually just kind of bumped Patrick Kane at the wrong time as they were coming towards the boards, and he just went into the boards kind of, shoulder first, and he hit his shoulder on the board before he kind of could brace himself. And as soon as we saw this happen, I said to my son, I was like, oh man, he probably broke his collarbone. And this is kind of the sign whenever you see somebody kind of get up from a fall and they're holding their arm really, really close to their body. Again, we said, once that clavicle kind of breaks, my arm is kind of only attached to my skeleton through my muscles. So it's hard for me to keep it out laterally. So this is anytime you see somebody get up like this, and he just kind of popped up off the ice, had his arm real close, and this is kind of telling you that, okay, he probably broke his collarbone when he fell. Okay, and this is through any kind of sport like cycling or hockey, baseball, anything like that. If you see somebody holding their arm pretty close, you want to suspect that they may have broken that collarbone. Okay, this is how you usually do it, is you hit something, you go over your handlebars, you put your arms out to sort of brace your fall, and then you end up kind of breaking that collarbone. And again, they kind of say in cycling or cycling racing that you're not a true cyclist till you've kind of broken your collarbone. But this can be kind of a little bit of a scarier way to kind of do it. But again, it can be any fall. But again, you're going to put your arm out to sort of break your fall and usually protect your head or other parts of your body. And you're going to end up sort of breaking that collarbone, which again is a much less of a serious injury than if you hit your head real hard. And this is, again, you'll see this in the Tour de France, which just kind of finished up on TV pretty recently, is that they'll have this big crash, and then they're holding their arm real close, and obviously they're going to kind of be palpating that collarbone to kind of see if they can feel any sort of damage. Okay, here is your picture of the clavicle. So again, I get a sternal end, and I get an acromial end. And then we want to move on to the scapula. And again, the scapula for the upper arm there's a lot of things to kind of label on here. So just really important that you know this one really, really well. And you also want to realize that I really like the shoulder just from chiropractic and sort of my own kind of injuries. The shoulder is one of those joints where I've always told people, if you can understand the way your shoulder works with the muscles and all the attachments, you can understand any part of the body, because we have just so many muscles that kind of pull it in all these different directions, and it gives you so much motion. So anytime your teacher really likes something, you know that it's going to be a focus on some of your exams. So scapula, also known as the shoulder blade, it's going to lie on the dorsal surface. So again, those terms come back all the time. So dorsal surface is that backside of your rib cage. Each scapula is going to have 3 borders, so you want to make sure you can label them. We'll see the picture here in a second. Superior, medial, and lateral. You're also going to have a glenoid cavity. This is where my humerus is going to fit in and kind of form my shoulder joint. And then because I have these 3 borders, I'm going to create these 3 angles. And again, I just want to make sure that I can label them: superior, lateral, inferior angle. Okay? And then we have a couple other landmarks that we want to be aware of. And again, anytime you see a bone for any labeling, the very first thing you want to do is just orientate yourself. Make sure you know if you're looking at it from the front, the back, the lateral side, the top, the bottom. So we're going to also want to be able to find the acromion, which we've talked about a little bit, the point of the shoulder, and this is where it articulates with the clavicle. We're going to have a coracoid process. This one's a little harder to feel. It's kind of buried underneath your deltoid, but it's going to project anteriorly, and these are going to be the attachment point for your bicep muscles. Okay, we're also going to get a suprascapular notch, which is just a passageway for some nerves, and then we're going to get a bunch of fossas, which is going to be this infraspinatus fossa, supraspinatus fossa, subscapular fossa, and these are going to be the fossas that your rotator cuff muscles are going to kind of sit in. Okay, but we get two in the back, which is for the infraspinatus, supraspinatus, and then we get one big fossa in the front, which is going to be that subscapular fossa. So again, you want to make sure you know if I'm looking at the front, the back, and then I can know which fossas I should be seeing and which ones I should sort of name. So here is a picture from the front. Okay, and you know you're looking at it from the front. So again, anytime you look at the picture, the first thing you want to do is, hey, am I looking at it from the front? Am I looking at the left one or the right one? So for this scapula, I know I'm looking at the front here because I can see this coracoid. And then when we look at the back, we'll sort of see one more structure that's going to help you sort of know if you're looking at the front. Okay, but I can see the coracoid. Okay, and what I do not see, which we'll see in the next picture, is this scapular spine. Okay, but I want to find all the angles. I want to find the borders, I want to find my subscapular fossa, and then I want to find my glenoid cavity, and then I want to be able to find that coracoid here, okay? So very important that we kind of can label all these things from all these different little directions. And then if I look at it from the back, this is my distinctive feature here, okay? I get this scapular spine, and I cannot see it from the front, so anytime I can see the spine, I know I'm looking at the posterior part of the scapula. I can still find the acromion, I can still find the coracoid, I can still find all my angles, okay, and my borders, glenoid cavity, but what I get is my fossas change. So above the spine, and again, I can reach back on my shoulder, and I can find my scapula, and I can find the spine, and then I can just move above the spine or a little bit more to the top, and I'll feel this little fossa, and I'll feel my muscle in there, and this is going to be my supraspinous fossa. This one is the muscle that's torn a lot in the rotator cuff, and it's also the one that a lot of times on people is really, really tender. So if you slide up above the spine and you push your fingers in there, a lot of times it'll be pretty sensitive, okay? If I go below or a little inferior to the spine, I get into this infraspinatus fossa, and that's where my infraspinatus muscle will kind of be, okay? So again, we're just talking about where these rotator cuff muscles that are going to hold my shoulder together, keep it nice and stable, this is where they're going to be located. So very important bone here, lots of stuff on here, lots of things that are going to end up on your practical. Make sure you can label this scapula really, really well. And then these will help you when we move on to the muscles, because the names are going to stay the same, and all I'm going to do is sort of put those muscles kind of into their proper fossa. So here's a picture from the side, okay? So this one is if we took your humerus or the top part of your arm out and we were just looking into the shoulder socket. We're going to come back to this when we talk about the rotator cuff and different kinds of injuries, okay? But this is where that head of the humerus is going to sit, and you can see where it's very shallow. And again, that's one of the things that gives it a ton of motion. But you can also see that when I put this bone in here, there's going to be a little gap here. And this is a problem that people run into all the time, where you'll get these little impingement syndromes. And what's going to happen is if my muscles are really weak on my shoulder or they're injured, that humerus is going to be allowed to sort of creep up, and it's actually going to run into this acromion. And the problem with that is that there's a bunch of arteries and nerves and muscles that have to fit through this little area. And it's probably one of the most common injuries that I see for shoulder pain all the time. As people get older and we start to become a little less active and those muscles get a little bit weaker, we're going to get these, again, these little impingement syndromes. And it's very, very important to keep those muscles strong, that you can keep that humerus kind of in that proper spot, and you can maintain this gap as you get older. Because again, this is how we sort of end up tearing that supraspinatus muscle. But we'll kind of come back to that as we move into the other chapters. This is also a good one to be able to label, okay, because I can find the acromion. This is a great picture where it shows you, okay, the coracoid is anterior, right? The acromion, the spine are posterior. And then this is the one everybody gets wrong here, is that they label this one a little bit wrong, okay? But this is going to be that lateral border, because when I go back this way, okay, this is going to be that medial border, and it's going to sit close to my spine. And you can see on this one, there's my glenoid cavity. This is going to be that lateral border. But this one always kind of tricks everybody, where I get to where I get this little border here. And you know that it's lateral because I can see that fossa, okay? And I know that if I can see the fossa, this is where my arm goes, and this is where that little lateral border is going to kind of be. So just another one that you want to kind of pay attention to. And again, you want to make sure you can label all these things from the front, the back, the side, the top, the bottom. So now we move on to the arm and the forearm and the hand. And this is going to be, again, our upper limb. And one of the things with anatomy is that a lot of times we think of the arm as just the whole arm. So top of the arm, below the elbow, down into the hand. For anatomy purposes, the arm is only the top part. Okay, so only the humerus is going to be the arm. The forearm is going to have its own distinction, and then the hand is going to have its own distinction too. So another one of those things that can pop up on your multiple choice test and just trick you a little bit. Okay, so here is your arm, and again, we're talking about the humerus, and we're going to have a proximal end and a distal end. Okay, so in proximally, it's going to form my shoulder. Distally, it's going to form my elbow for me. And that's another really important thing, is to know sort of where these bones come together and what joint are they forming. Okay, so my humerus is the sole bone of the arm. So again, the arm is only the top part. The proximal end's going to fit into the glenoid cavity of the scapula. The main things you want to be able to label are the greater tubercle, that's going to be a little more lateral, and the lesser tubercle, that's going to be a little more medial. In between the tubercles, you're going to get this intertubercular sulcus. So it's a big long name, but it just means in between the tubercles. And it's just going to separate them, and we can put some tendons and some other things in there too. We're also going to get at the proximal part this surgical neck. It's going to be a little inferior to the tubercles. You'll see it in a picture here, and it's going to be one of these things that we can kind of easily break to. So again, we're looking at the proximal part of the humerus, a little higher, right? And this one is going to form my shoulder joint. So this head here is going to fit right in that glenoid cavity, and it's going to again form my shoulder joint. So I can see the two tubercles, greater tubercle, lesser tubercle. In between the tubercles, I get my little sulcus here, and then down this way a little bit inferior to the head, I get that surgical neck. So at this point, you want to be able to say, okay, if he gives me the humerus, if he's going to ask me to label something on the proximal part, it's going to be the tubercles, it might be the intertubercular sulcus, probably the head, maybe the surgical neck, but you want to start making your list of all the important parts of these proximal and these distal parts of the bone. And then also remember that, okay, the proximal part meets up on my scapula, forms my shoulder for me. Okay, so other landmarks that you might find on the humerus, if you go halfway down the shaft, you're going to find this deltoid tuberosity. And all of you, if you kind of put your fingers on the deltoid and you kind of follow it down the side, it kind of forms this little point, kind of the little teardrop shape. Where it inserts on that humerus is going to be that deltoid tuberosity. So again, I can palpate that, and I can put my fingers on there. And then we'll also have this little radial groove, which is just a pathway for that little radial nerve as it's moving down the arm. We look at a picture of the humerus here, and again, meeting up with my scapula to form my shoulder joint. We've talked about the proximal part, okay, and we want to know the tubercle, lesser tubercle, sulcus, and then here is my little deltoid tuberosity, and I can see on this side here this little radial groove, okay, but really concentrate on just those main, most important things for all these different bones, and then we'll get into the distal part, which is again going to form my elbow for me. So here is the distal end, and again, we want to make sure we know the distal part of the humerus is going to meet up with my forearm bones and form my elbow, and then we'll kind of keep moving a little more distally until we get down into the hand and the fingers. So the distal end, one of the important things to remember is that you're going to have a condyle and you're going to have an epicondyle. Okay, so the epicondyles are the part of the bone where they kind of widen. You can see in these pictures where they're going to start to kind of widen a little bit as they get down towards the joint. Those are going to be those epicondyles. Okay, and then the condyles are going to be the ends of the bones. Those are going to be the parts that are going to kind of be covered in cartilage, and that's actually going to be the part that kind of forms the joint, and that's going to be the same kind of throughout the body. Okay, so epicondyles are where I attach muscles. Condyles covered in cartilage, those are the ones that are going to form those joints for me. So I get a medial and a lateral epicondyle, and again, I'm going to attach muscles in there. My ulnar nerve is going to run behind the medial epicondyle, so if you just put your arm out in front of you and you have your thumb or your palm facing forward, okay, just like anatomical position, that medial big bony spot on the inside part of your elbow that people call the funny bone, that's going to be that medial epicondyle, okay, and if you put your fingers just behind it, you can kind of move it back and forth, and you can actually feel that ulnar nerve, and you can actually feel that kind of radiation kind of down into the fingers a little bit too. The humerus also has two condyles. Another two important things that you want to make sure that you can label. We're going to have a trochlea that's going to be a little more medial, and we're going to have a capitulum, and that's going to be a little more lateral. Okay, and these are going to articulate with my ulna, my radius. Very important to know which one goes with which. Okay, so ulna is going to go with the trochlea, and then the radius is going to go with the capitulum, but they're going to kind of be those forearm bones. But again, they're coming up to kind of make my elbow joint for me. Okay, we also get a couple other little landmarks, and we get some other fossas. So these are fossas that are on the distal humerus. We get a coronoid fossa, okay, different from the coracoid. We get an olecranon fossa on the back side, and then we get a radial fossa, and this one's going to be a little more lateral, and this one's going to be, again, for that radial head. But these are just going to be little depressions or little fossas where the forearm bones, okay, they're going to kind of fit into these as we sort of bend and straighten our elbow. So when we straighten it, we're going to lock these bones in place by kind of fitting them into different little fossas. And it'll make more sense when we look at the picture here. So here is our picture of our distal humerus, okay? And this is where I'm looking at the anterior side. Here's that little medial epicondyle. But I can see I get a coronoid fossa, okay? And then I get a radial fossa, and then these are my forearm bones. And when I bend my elbow fully, these little points here are going to fit into those little fossas, okay? So when my arm is bent, I lock them into those fossas on the anterior side. When my arm is straight, so this is my olecranon, or the big bony spot on the back part of your elbow. But when my arm is straight, I lock this olecranon sort of into this olecranon fossa, and again, it just gives me a little bit more stability, okay? But very important to, this little medial epicondyle is going to help you when I'm looking at that front side of the humerus. It's going to let you know, because it's so prominent, that this is the medial side. And then that's going to help you remember that, okay, on the medial side, I have my trochlea, and I also have my ulna, because they're going to run medial. And then on the lateral side, I'm going to have my capitulum, and I'm going to have my radius. So this is one of those things that you just have to kind of memorize, and you have to be like, okay, ulna's on the medial side, radius is on the lateral side. Radius is going to kind of follow the thumb a little bit, okay? So again, good picture to sort of label all those little important parts on that bone. So here's a zoomed in picture. Humerus, big prominent medial epicondyle. Here's my little olecranon fossa, and then I get my lateral epicondyle, medial epicondyle. I can't quite see the joints quite yet on this one yet though, okay? But I can see my ulna on the medial side, and I can see my radius on that lateral side, right? And then here's a picture from the front. This is also like when I look at this picture, I know this is the posterior part of the elbow because I can see the olecranon, okay? And I cannot see the trochlea, and I cannot see the capitulum. So if I give you this picture, the very first thing you want to do is be like, okay, am I looking at the anterior or am I looking at the posterior part of the humerus? Because I can see the capitulum and because I can see the trochlea, I know I'm looking at the anterior side. Okay, and this can help me know left or right. It also kind of helps that I know that this is the medial epicondyle, because that's going to help me sort of with the left and the right side too. Okay, so again, this can be a little tricky, just one of those things that you want to just keep practicing on all the little images, and then we'll go back and we'll do some of the blue door stuff a little bit too, just to help us a little bit. So now we get to the forearm bones. We have two parallel long bones. We've already said they're going to be the ulna and the radius, but we want to know sort of what joints are they important for. Ulna is going to be medially, okay, so on the medial side in anatomical position. My radius is going to be lateral, and it's going to be again on that thumb side. The proximal end is going to articulate with the humerus, and again, they're going to form my elbow joint, right, proximally. And then the distal ends are going to be obviously farther away, and they're going to form my wrists with the bones in my hand. Okay? We're also going to have this interosseous membrane, and we'll see that in a picture here too, but it's going to be this flexible membrane. It's going to connect them along their length. Okay? So here's our little picture. This is my ulna, okay? And then this is going to be my radius. And I can kind of see up here where this is going to lock in and form my elbow joints. The other thing you're going to notice is that the ulna is going to play a much bigger role at the elbow, and the radius, as you can see, because it's way bigger down here, is going to play a bigger part in my wrist joint. Okay, so another important thing, another good multiple choice question. But here I can see that little interosseous membrane that just keeps these bones from being kind of pulled apart. Here's a picture from the back side, kind of same thing. Big, huge ulna up at the elbow, and then I get the big, huge radius down by my wrist. And we'll see that in a second too when we move on to the wrist joint. So my ulna is going to form my elbow joint with my humerus. The radius really does not do very much, and as you'll see from the picture, it's really not even touching anything except for the elbow, or except for the ulna, okay? So the proximal end, we get two processes that are separated by a trochlear notch. We're going to get this olecranon process, and then we're going to get this coronoid process. And these are going to basically form like a wrench, okay? And they're going to grip the trochlea of the humerus, and they're going to create this hinge joint, but they're going to create this really, really solid, kind of stable elbow joint, okay? The radial notch is also going to be in there, but again, the radius up at the elbow is really just kind of along for the ride, and it's going to allow me mostly to just kind of supinate and pronate and sort of turn my palm up or turn my palm down. So here is a picture of that proximal ulna, okay? And I get the olecranon, or the big bony spot on your elbow, and I get the coronoid, and then we're going to see another picture where we'll sort of see how it fits together with the humerus a little bit better. But you can see I also get this little radial notch here, and we'll see the picture again in a second here. But again, the radius is just going to kind of spin in this notch, and it's allowing that kind of crossing over of those forearm bones. So at the distal end, there's not much going on, and the only thing that I would really ask you about the ulna at the wrist is going to be this little styloid process, okay? Because again, it's not really playing a big role down at the wrist. It's more, again, creating that elbow joint for me with the humerus. here is a picture of your ulnar styloid, and I can see that my radius is way bigger down by the wrist, which we'll talk about in a second here again. Okay, but here is a great picture from, it's one of those where sometimes you don't find a good picture in your textbook, so you have to kind of search on the internet. And this is just one that I found that it really shows how that ulna is kind of creating this little notch here and how it's fitting and sort of locking that trochlea in there. So this is my humerus. This is my trochlea, right? And then I can see this is my olecranon. This is my coronoid, and I can see I get this little trochlear notch here, and it just fits right in there and then creates, again, this really just very stable hinge joint up at my elbow. Okay? And one of the other questions that I always get is, how do you know this is the medial epicondyle? How do you know it's not the lateral epicondyle? But what you have to do is kind of look at the bones here. And what you're doing is you're sort of saying like, okay, this radius is farther away from me, right? And we know the radius is on the lateral side. So we know the radius goes with the lateral side, and we know that the ulna is on the medial side. So we know that this is going to be that medial epicondyle. Okay, but we can see how this just creates this really, really stable joint. And we can also see how if I bend this elbow fully, this little coronoid is going to fit up in this little fossa. And if I straighten my arm fully, this little olecranon process is going to fit in that little olecranon fossa, just to give us a lot of stability. So a really good picture at just kind of showing you all the important parts and how they kind of fit together for the elbow. So now we get to the radius. And we said the radius is really just kind of along for the ride and creating this rotation sort of out by the elbow. But when we get down a little lower and we get a little more distally, it's going to be really, really important for my wrist joint. Okay, so the proximal end is thinner. It's going to articulate with the capitulum of the humerus. Okay, the distal end, again, is going to be thicker. We saw that in the picture. And we're going to have this ulnar notch. We're going to have, again, another styloid process. Okay, but we want to really, really understand that this distal part is really important. And it's articulating with all the carpal bones or the small bones kind of in my hand. And it's going to create this wrist joint for me. And we're going to see, again, one of the real common kind of fractures that happens in the wrist is going to be this Colles fracture. And this is where I break the distal end of this radius. And again, this one's usually for a fall where I put my hand out to sort of break my fall, and I end up sort of breaking my wrist and a lot of the bones kind of down into my hand. So this is a scaphoid fracture. So this is where I slip on the ice. I put my hand behind me, and you want to think about I bend my wrist backwards, or I put it into extension, and I kind of land on the base of my hand. And what I end up doing is that I end up just jamming this radius and this ulna, and predominantly this radius, into the bones in my hand, and I end up sort of fracturing a bunch of bones in here. Okay, and what happens is there's a Colles fracture and there's a Smith fracture, and it's all just based on what position is your wrist and when you fall. The Colles fracture, your wrist is in extension or it's bent backwards, okay? And then I land on the heel and I just jam all the bones together and I create a bunch of these fractures. And what you'll do is you'll break the bones in your wrist, and you'll also break the end of this little radius, okay? If I fall again in flexion, usually I don't break the bones in my hand, but I'll still break the radius and I can still break the ulna a little bit too. But again, I fall in flexion, it kind of limits some of the impact in there into the smaller little carpal bones. This is a picture of my little guy. So he was probably like 7 or 8 years old, and he kind of fell and again just put his wrist out to sort of break his fall. But this bone, this part right here, this is actually the distal part of his radius, okay? And you can see where this is supposed to be up here, and it's just snapped right off. And this was one where he kind of fell and he had a long sleeve shirt on, and I kind of ran over there to see if he was okay. And then when I rolled the sleeve up, you could see that his wrist was no longer where it was kind of supposed to be. And then we had to sort of go off to, the emergency room, and the next day he had surgery. But again, you can snap off just this whole little end of the bone here when you fall. So it can be a really, really serious kind of fracture. So this is after the next day when he had surgery. Okay, so they had to take this distal part of the radius and put it back where it's supposed to be. And then people are always like, hey, what's this here? Pointing. But this is actually the pin that they put into the bones. They just drilled a hole and sort of stuck this pin in there. And this is just a really cool thing. So Lennon kind of fell, he was just really, a couple months from hockey season kind of starting. And we went into the doctor, and again, his wrist wasn't even located where it was supposed to be. And they said, hey, you know what, in 8 or 9 weeks, he'll be back to playing hockey. And I really felt like, hey, there's no way, his wrist is not even in where it's supposed to be. There's no way he's going to be back to hockey in 8 weeks. But what they did was they put this pin in there. They put a cast on him. They brought him back in 4 weeks, okay? They took his cast off. They took these really fancy pliers, and they kind of just yanked this pin out of there. and then they put him in another cast, and then eventually they moved him into a brace. But it was really, really amazing just how quickly they could kind of get him in this brace, get him to start moving his wrist, get him to start doing some ranges of motion, and really within that 8 or 9 weeks, he was back to playing hockey, which is pretty spectacular. You know, it used to be where they just put your cast on, you'd get your cast off, your wrist would have no motion, you would have to spend months and months and months just getting that motion back. But we've learned over time that just immobilizing things is just a really, really bad thing, because what happens is you just build up a bunch of scar tissue on all these bones, and then when I get my cast off, my motion is really, really limited, and I have to spend a ton of time sort of breaking down that scar tissue. So they've really learned that, you know, they want to get these joints moving as quickly as possible so that you get the healing, but you get it in a really more functional sort of way. Okay? And so this is, again, they just yank that pin out, put the cast on. 8 or 9 weeks, he was back to playing hockey like it never happened. This picture is also really cool, and we're going to talk about this in chapter 6, because you can see, because he was so little and he was still growing, you can see his little growth plates in here, right? So they can do these little x-rays, and what they can do is they can tell if you're still growing by whether these little growth plates are kind of sealed up a little bit, okay? So these aren't two different bones. This is just that layer of cartilage that the bone is growing from, and then it's going to continue to kind of lengthen. Now, one of the other things that's really, really serious is if he would have fractured it and sort of disrupted the end of the, because he broke it sort of down here, right? He didn't break the end of the radius, whereas if he would have broken this end where the cartilage is still trying to grow and the bone is trying to lengthen, this bone would no longer grow properly. Okay, so that becomes any fractures, especially in little kids, kind of down by the joints, are really, really, really important to get them taken care of properly, because again, you can disrupt the whole growth pattern of the bone. And then with older people, your bone is fully grown and you fall and you sort of break the end of the radius and you sort of disrupt all this cartilage. Usually what that means is that you're going to get some pretty severe arthritis as time goes on in that wrist too. So bones, you know, if you break a bone in the middle, usually they heal awesome. If you break them down by the joints, they're much more serious and much more important to sort of get them taken care of properly. The other question I always get is, how exactly did he break his wrist? And this is how he broke his wrist, on a hoverboard, okay? And if you guys have ever had a hoverboard, you know how you make them go fast is you kind of lean, right? And the more you lean, the faster they go. And the problem with falling is that as you're falling, you're leaning pretty significantly, and this thing starts to really go just faster and faster and faster. Whereas when you're falling, what you need to do is stop. But I mean, you know, what it does is just accelerate, and it just makes the fall even more powerful. Okay, so wear your wrist guards, wear your elbow pads, all your other stuff, because again, you can really, really kind of hurt yourself pretty quickly and sort of create a lot of problems kind of down the line. So here are my forearm bones again. And again, we want to make sure we know the ulna comes up and really is very prominent for my elbow joint, okay? And then my radius comes down. It's way bigger at the distal part, and it's going to form that wrist joint for me. So now we get to the hand, and there's a bunch of bones that we have to just kind of label, and you have a lot of bones in your hands and your feet. So, you know, these are, when you talk about how many bones are there in the body, the bones in the hand and the feet are going to account for a lot of those, okay? So here is a picture of your hand. And again, I know this is the radius because it's bigger, okay? And I know it's the radius because it's on the thumb side. So very, very important to kind of orientate yourself. And I can see that this is really coming into contact with these little bones in my wrist. And I can see that the ulna is kind of spaced out, and it's not really doing too much down by the wrist for me, okay? But I can see this part right here would be kind of like the palm of your hand or the back of your hand. And these are these rows of carpal bones for my wrist joint. And then I get down into the phalanges, and I get down into sort of my fingers, or what we think about as the fingers. So here is the carpus, or the wrist. So proximal part of the hand, and this is just off the ends of the radius and the ulna. Okay, and I can really put my two fingers right at the ends of my radius and my ulna, and I can feel a lot of these bones, and if I push them back and forth, I can feel them all sort of moving around. But it consists of 8 marble-sized carpal bones. They're arranged in 2 irregular rows of 4. You have a proximal row just off the end of the radius and the ulna, which is the scaphoid, lunate, trichotram, pisiform, and then I get a distal row, so 1 row farther, trapezium, trapezoid, capitate, and I get this hamate, okay? And again, yeah, you do have to memorize and be able to label each of these bones. And you know, because I said with the falls, a lot of times you're going to jam this radius into these 2 bones here. So it's going to be the scaphoid and the lunate. Those are the ones that are going to kind of get broken, okay? So here is my radius, ulna. This is my proximal row, and then this is my distal row. Okay, so again, you got to kind of be able to just make sure you can label all of these for practical purposes. And then always knowing which ones get broken or which ones are most easily kind of fractured is a good idea too. This is how we used to remember them in chiropractic school. So you can find a lot of these kind of online. And again, the sillier they are or the goofier they are, the easier they are to remember. So we used to say some lovers try positions that they cannot handle. The first letter of each word kind of gives you the first letter of each of these bones. Now, the only tricky part for this one, and again, you can find different ones, is that you're always starting, okay, on the thumb side, proximal row, and you're going this way, and you're coming back to the thumb side, and you're going across this way. So it's, some lovers try positions, okay, and then you got to come back here, that they cannot handle. And again, I just want to know the first letter, and then that'll help me sort of remember what the names of the different little bones are. So again, if this one helps you, awesome. If you can find another one that's easier for you to remember, awesome. But remember, you're going this way, and then you're coming back to the thumb side and working your way across this way, okay? So important, again, just for more labeling sort of purposes. So we get to the metacarpus, which is the palm. You have 5 metacarpal bones. They're going to radiate from the wrist to form the palm. Okay, so these are coming off of those carpal bones. They're moving up, and they're going to kind of form, distally, they're going to form those big knuckles. More approximately, they're going to kind of form that wrist joint for me. So they're numbered 1, 2, 5. They're going to start with the thumb. So the thumb is number 1. The base is going to articulate with the carpals, again, to form the wrist. The heads are going to articulate with the fingers, and again, those are forming those big knuckles for me on my fist. Okay, so here are my metacarpals. Okay, so that's the base. This one is going to be the distal part. Again, this is going to form kind of like the wrist joint here for me a little bit. And then again, these will be the back of my hand or the palm of my hand. But I'm labeling them from 1 to 5. And again, this is important. If I get a fracture, you want to make sure you're specifying sort of what finger you're talking about or which part of the hand you're talking about. So we're going to label them, and we're always going to start with that thumb side. Okay. But again, metacarpals. And then I get to my fingers, or the proper name for the fingers are going to be the phalanges. So these are my fingers, my digits. Again, I'm always going to label them 1 to 5. I'm going to always start with the thumb again. Each finger is going to have 3 phalanges. You're going to have a distal, a middle, and a proximal. We'll look at the picture in a second. Except for the thumb, and it's only going to have 2 of these, okay? There's no middle phalanx. It's only going to be the distal and the proximal. So we come back to this one. We find the radius, find the ulna. We have our rows of carpal bones. We have our metacarpal bones, and then I get into the phalanges. So proximal, middle, distal. But when I'm on my thumb, okay, I only have the proximal and I only have the distal, which makes it a little bit shorter, okay? So make sure you kind of, if you get this in your practical, you want to be able to say this is, the first metacarpal, or this is the first phalange, and then specify the specific part that it's kind of pointing to. So don't forget those numbers for your labeling purposes. Okay, and this is just a little summary. You always want to kind of bring everything back together and think of the whole arm as one. So you want to remember this is like my shoulder girdle. We're getting into that upper extremity, but it's clavicle, scapula, humerus. You got the radius, you got the ulna, and then I got all those little bones in my hand that you want to sort of make sure that you can kind of label. And again, really concentrate on, okay, what joints do these form? What do they come together? Proximal end, distal end. What are the landmarks? But what part of the body, what joints do those kind of form in the body for me? And then you have this little just upper extremity review, which has a bunch of the little pictures after you sort of memorize them, just to sort of reorientate yourself and just make sure you can find all those little landmarks on there. Okay, so you want to take the practice images, you want to take the lab objectives, you want to make sure you can label all these things on the images, and then again, we're going to use some of the images from the Blue Door Labs a little bit too. Okay, and then we're going to move on to, next time we'll move on to the lower extremity, and then we'll look at how the bones come together and form the joints of our body, and then we'll come back and we'll look at all our physiology for the bone chapter.